All right, good evening, everyone, and welcome to another lovely session of our residence webinar series. My name is Dr. John Afamosemene. I am the trainee representative of the Nigerian Society of Anesthetists, and it's my pleasure, my utmost pleasure, to welcome everyone to this 15th webinar session of the 15th residence webinar session of the Nigerian Society of Anesthetists. We are deeply grateful to the executive committee of the Nigerian Society of Anesthetists, led by Professor Hassan Dati, and the educational committee, led by the president-elect, Professor Quinette Kalu, for their support, for their encouragement, for their knowledge in helping us to power this series. And we the residents are deeply grateful for them for this opportunity to increase our knowledge and increase our community participation in NSA activities. I will be introducing our moderator for today. Our moderator for today is Dr. Paul Oyebola. Is a senior registrar in the Uni Osun Teaching Hospital, Oshogbo. Dr. Paul, welcome to the webinar. How are you doing?
Good evening, sir.
Good evening.
Thank you, sir. I'm fine.
You have the floor.
All right. Thank you, sir. Good afternoon once again, our teachers and respected colleagues. We are on at the 15th session of the resident webinar of the NSA. And this afternoon, we have Dr. Victoria Emmanuel, who will be educating us on perioperative management of patients with heart failure. She is a registrar in the Department of Anesthesia at the University of Calabar Teaching Hospital in Calabar, Cross River State, Nigeria. So for the next few minutes, she will be educating us on this topic. I want to encourage us all to pay attention and then, as much as possible, keep our microphones muted. And also, if we have not by now, I will encourage us to rename our devices to reflect our name, our real name, and the institution that we represent or we come from. So thank you very much. Dr. Victoria Emmanuel Ndoma, you have the floor, ma'am. Thank you. Dr. Victoria. Dr. Victoria. Okay. I think we have to wait for Dr. Victoria. I guess she's having maybe network challenge or technical difficulties. Okay. We can see your screen, but you removed the presentation.
Please let me open the document again.
All right. Okay, we can see your screen now.
Good evening, Professor. consultants, senior registrars, and registrars. I am Dr. Victoria Emmanuel Indoma of the Department of Anesthesia, University of Calabar Teaching Hospital, and I'll be presenting the topic perioperative management of patients with heart failure. This is my outline. The objectives of the presentation will be to identify perioperative risk, optimize patients perioperatively, and outline intraoperative and postoperative management. Heart failure is a heterogeneous syndrome in which an abnormality of cardiac function is responsible for the inability of the heart to pump blood at an output sufficient to meet the requirements of metabolizing tissues, or to do so only at abnormally elevated diastolic pressure or volume. Heart failure is characterized by signs and symptoms of intravascular and interstitial volume overload, including shortness of breath, rales, edema, or manifestations of inadequate tissue perfusion, such as impaired exercise tolerance, fatigue, and renal dysfunction. It affects 64.3 million people worldwide, 1 to 3% of population in high-income countries, and major risk factors are age, hypertension, coronary artery disease. Perioperatively, heart failure is associated with substantial increase in morbidity and mortality. Heart failure can be classified as left-sided and right-sided failure, also known as cor pulmonale. According to the 2013 American Cardiology College and the American Heart Association classification based on ejection fraction, heart failure can be classified as heart failure with reduced ejection fraction or systolic heart failure, and heart failure with preserved ejection fraction or diastolic heart failure. The European Society of Cardiology also classified heart failure based on ejection fraction as heart failure with reduced ejection fraction less than 40%, heart failure with mildly reduced ejection fraction with ejection fraction of 40 to 49%, heart failure of preserved ejection fraction with ejection fraction greater than 50%. The 2022 American College of Cardiology and American Heart Association guidelines describe heart failure with 4 distinct stages. Stage A, heart failure at risk. Patient is at risk of heart failure but doesn't have any structural heart disease or symptoms of heart failure. Stage B, patient has structural heart disease without signs or symptoms of heart failure. Stage C, patient has structural heart disease with prior symptoms or current symptoms of heart disease. And then stage D, refractory heart failure requiring specialized interventions. Etiology of heart failure. The main causes of heart failure include ischemic heart disease, dilated cardiomyopathy, and hypertension. Other causes include undilated cardiomyopathy, valvular heart disease, congenital heart disease, substance abuse, chemotherapy, hyperdynamic circulation such as anemia, Paget's disease, thyrotoxicosis, right heart failure, arrhythmias, and infections like myocarditis, endocarditis. Pathophysiology of heart failure. Apoptosis or cell death of myocardial tissues results in cardiac dysfunction, leading to reduced cardiac output. When this occurs, there is stimulation of the carotid baroreceptors, and then there is reduced renal perfusion. Owing to this, the activation of the sympathetic nervous system and the renin-angiotensin-aldosterone system is activated. This system, the sympathetic nervous system, is responsible for increasing heart rate and contractility of the heart. This is to compensate for the low perfusion and reduced cardiac output. At the same time, the renin-angiotensin-aldosterone system causes vasoconstriction peripherally, increasing the afterload and also the preload. Owing to this, the heart senses this reduced cardiac output, and there is release of the B-type natriuretic peptide and the A-type natriuretic peptide. All of this is trying to counter the effect of the renin-angiotensin-aldosterone system, but this activity is short-lived as it is overpowered by the renin-angiotensin-aldosterone system, leading to negative remodeling of the heart, whereby the heart loses its truncated shape and it becomes globular, and then there's myocardial injury leading to worse left ventricular function. So in a bid to address this situation, we have the introduction of the angiotensin converting enzymes inhibitors, angiotensin receptor blockers, aldosterone antagonists, and antidiuretic hormone antagonists. These medications help to counter the effect of the renin-angiotensin aldosterone system because prolonged stimulation of the renin-angiotensin-aldosterone system initially may compensate for the heart failure, but chronically it causes decompensation, leading to the symptoms of heart failure, dyspnea, orthopnea, PND, peripheral edema, fatigue, and exercise intolerance. So medical management of heart failure include use of diuretics, the loop diuretics, and for patients with low ejection fraction, less than 25%, aldosterone antagonist is introduced. Vasodilators are also used to manage heart failure. Aldosterone, angiotensin converting enzyme inhibitors like the lisinoprils and captoprils, angiotensin receptor blockers are used. In cases where patients are intolerant of the ACEIs and the ARBs, hydralazine and nitrates can be used. Beta blockers are introduced when patients have arrhythmias to reduce the heart rate and reduce myocardial oxygen demand. Ionotropes like digoxin are used to improve symptoms in arrhythmias and patients that have sinus rhythm with worsening heart failures. Anticoagulation, patients with heart failure are prone to thromboembolism, so we need to give them anticoagulants to reduce the risk of thromboembolic events. Cardiac resynchronization therapy with the use of biventricular pacing devices are used when patients have intractable heart failure. At the same time, when intractable heart failure persists, the patients may need automatic implantable cardioverters or defibrillators inserted. Anesthetic considerations for these patients include fitness for surgery. We have to ensure that the patient is fit, checking their ejection fraction. If it's less than 30%, the patient may have to be deemed unfit for surgery, especially for elective surgeries. And then in the case of emergencies, we have to explain to them the risk of undergoing surgery, saying the fact that they can barely decompensate for any alteration in their physiological balance. They will also have difficult IV access because of repeated hospital admissions and IV administration. So, and most of the time, edema also makes it difficult to access their IV lines. Choice of anesthesia is dependent on the procedure and the patient's stability. Is this patient stable, compensated, or decompensated? When the patient is stable, we can do local anesthesia for peripheral procedures or regional technique dependent on the site of surgery. For regional techniques, epidural anesthesia is preferred to subarachnoid block because it helps to blunt the marked hypotension that occurs with the use of subarachnoid block. But with epidural, we can titrate the anesthetic agent and we are able to avoid hypotension as much as possible. General anesthesia can be considered for major surgeries. The goals of anesthesia is to minimize negative ionotropy, to minimize tachycardia, minimize diastolic hypotension and systolic hypertension. Careful fluid balance is also considered for this group of patients because we want to avoid fluid overload And as much as possible, we also don't want to tip them into acute kidney injury. Invasive cardiovascular monitoring is required for all major surgeries. Monitoring of urinary output is essential. And then drug selection for them. Any drug that is cardio-friendly are the drugs that we'll consider for patients with heart failure, because we want to avoid myocardial depression as much as possible. Post-operatively, we need to consider that these patients will have to be in the high dependency unit or the intensive care unit, and they will need good analgesia with avoiding NSAIDs because of kidney injury and supplemental oxygen. During the preoperative assessment, the goal is to assess the state of this patient. Is this patient currently having any acute signs of heart failure or not? So we'll be checking for the functional capacity of the patient. One MET is oxygen consumption of a resting adult, which is 3.5 ml per kg per minute or 250 ml per minute. So we want to assess, can this patient move about? What amount of daily activities can this patient carry out? 1 MET, 4 MET, 7 MET, or 10 MET? The state at which we can say that the patient is fit is if the patient has more than 4 METs, which is the patient can move about, the patient can carry out light tasks, can move about 2 blocks or more without having dyspnea and having any form of cardiac decompensation. The New York Heart Association classification is also used, the class 1 to class 4, where class 1 means there's no symptoms of heart failure, patient can go about their normal activities. Class 2 means that there's mild limitation, whereby patient only notices or has symptoms of heart failure when there's moderate exertion. Class 3 means there's marked limitation of activities. Patient has symptoms of heart failure with mild exertion, and class 4 is symptoms of heart failure seen at rest. So if this patient has class 3 or class 4 New York Heart Association classification, we know that this patient is decompensated and surgery should be postponed, especially if it's an elective surgery. So we look out for the other symptoms of heart failure, and then the drug history, knowing that they are always on beta blockers, anticoagulation, ionotropes, ACEIs, and ARBs. We need to confirm the medication the patient is taking to counsel appropriately, knowing that the beta blockers will be continued until the morning of surgery. The ACEIs would not be taken on the morning of surgery. Anticoagulation, depending on what type of anticoagulation the patient is on, you would have to counsel appropriately. Examination for volume status, checking for raised jugular venous pressure, bibasal crepitations, peripheral edema, arrhythmias, tachycardia, ascites, hypotension, tender hepatomegaly, all to assess patient's function pre-operatively. Investigations we would like to review the ECG to check for arrhythmias or to check if there's elevated ST segment, checking for old infarct or any current infarct, checking for, we would also want to find out the last hospital admission for this patient, if the patient has been able to go about activities in the last 6 months without any hospital admission. Transthoracic echo to check for ejection fraction, to check the state of the valves, pulmonary pressures, chest x-ray, looking out for signs of pulmonary congestion, full blood count, checking for anemia, thyroid function test, to check for elevated thyroid hormones, electrolyte urea and creatinine to check for electrolyte imbalances and kidney function. Check also the fasting lipid profile, fasting blood glucose. Risk stratification. So every patient coming for surgery, there are several guidelines that we can use to assess them for surgery, checking if they are fit or if surgery should be postponed or if further optimization should be done. So the Goldman risk stratification can also be used, the revised cardiac arrest risk index, the perioperative cardiac risk guidelines, and functional capacity assessment. Also, surgical risk, what kind of surgery is the patient going for? Is it a major surgery, a minor surgery, and the rest of that. Patient optimization would include postponing elective surgeries in decompensated patients, ensuring that the patient's volume is optimized, fluid volume is optimized. The guideline-directed medical therapy using the 2022 American College of Cardiology guideline that beta blockers are continued up till the morning of surgery, ACEIs are discontinued on the morning of surgery, diuretics are continued to the morning of surgery, ionotropes, the patients are on ionotropes, digoxin is continued to the morning of surgery, aldosterone antagonists continue to the morning of surgery. Then antiplatelets are discontinued 5 to 7 days prior to surgery, warfarin discontinued 5 days prior to surgery, and low molecular weight heparin commenced, which is discontinued 12 hours prior to surgery. We check out that the patient has good control of comorbidities. Patient has good control of comorbidities, hypertension, diabetes, anemia. Patient is fully optimized. Patient counseling and consent. And then we involve other disciplinary teams in the management of this patient perioperatively, the cardiologist, the nephrologist, the nursing staff, the anesthetist. A team briefing is done prior to surgery and after surgery so that everybody is on the same page as regards this patient. Communication and planning cannot be overemphasized because these patients are high-risk patients. So we have to ensure that as much as possible, every loose loophole is filled. We ensure fasting guidelines, ensures that we have good intravenous access prior to surgery, ensure thermoneutral environment. Our machines, we ensure that the suction is available, oxygen and the means of delivery is available. The automated external defibrillator is available. The manual defibrillator is available. Resuscitation drugs are drawn and labeled, and airway equipment are ready for resuscitation prior to any surgery. As much as possible, we avoid sedation, and then we ensure that antibiotics must be given because they are at risk of having infections. Anticholinergics are avoided because of their side effects, which is bradycardia, hypotension, and arrhythmias. Patient is nursed in cardiac position. Intraoperatively, the standard monitoring will be done for this patient, which includes temperature, pulse oximetry, measuring the pulse rate and the peripheral oxygen saturation, non-invasive blood pressure, the echocardiogram, and end-tidal carbon dioxide, and then hemodynamic monitoring for major surgeries. So invasive monitoring with central venous pressure to monitor cardiac output and prevent overhydration, intraarterial line measuring the beat-to-beat blood pressure, pulmonary wedge pressure to measure left ventricular pressure. Vasopressors and ionotropes will be available. The goal of ventilation is low tidal volume, avoid high PEEP, avoid hypoxia, avoid hypercarbia, and we want to prevent pulmonary edema and acidosis. Prior to induction, we obtune the laryngeal reflex with lidocaine, and then induction is done with a short-acting benzodiazepine or etomidate. Ketamine is used cautiously, weighing the pros and cons, the benefits and the risk for this patient, because as much as possible, we want to avoid tachycardia, systolic hypertension, and diastolic hypotension. Low dose propofol can be considered if we do not have other options available. For maintenance of general anesthesia for this patient, the preferred inhalational agent is sevoflurane because it is cardiostable, causing minimal cardiac myocardial, it does not reduce myocardial contractility. And even though it causes vasodilatation, it is something that these patients can cope with compared to other inhalational agents. The muscle relaxants preferred for these patients are vecuronium and rocuronium. This is because they also cause minimal cardiac they have minimal cardiac events. They do not reduce myocardial contractility. They do not cause hypotension. But pancuronium and atracurium should be avoided because atracurium causes histamine release, leading to hypotension. Pancuronium causes tachycardia, which is what we want to avoid to reduce myocardial oxygen demand. Use of suxamethonium is with caution because it is short-acting. It can be used for short procedures, but for long procedures, we do not use it to avoid bradycardia. The best form of analgesia for this patient is multimodal analgesia to prevent overdosing with opioids. Short-acting opioids are preferred. Long-acting opioids are used with caution because there is delayed respiratory depression and we want to avoid hypotension from the release of histamines if we are using morphine. Acetaminophen is safe for patients with heart failure, but NSAIDs should be avoided because there's risk of kidney injury, worsening fluid retention, and worsening heart failure. We can also consider regional analgesia or nerve blocks. This is to reduce the use of systemic opioids. Fluid management is something we have to be cautious of in patients with heart failure because already we are battling with keeping them at a balance, preventing increased afterload or increased preload. So we use it restrictively. Fluids are used restrictively, preferably crystalloids, not colloids. Approximately 10 ml per kg per hour or less, depending on patient's needs and depending on what we have on our monitors. We monitor urinary output, ensuring that it is between 0.5 to 1 ml per kg per hour. Intraoperatively, we have to look out for these risks: myocardial infarction, arrhythmias, hypotension, pulmonary edema, acute kidney injury, because these patients are prone to having this risk intraoperatively, and they could also have a cardiac arrest. So we have to monitor them closely. Blood transfusion is only given when necessary with the hemoglobin less than 8 grams per dl, and if not, we would, as much as possible, avoid blood transfusion and use other alternatives such as using the surgical techniques, diatemy, using antifibrinolytics. Monitor hemodynamics closely, and if blood transfusion must be done, it must be done using diuretics for volume-sensitive patients, done slowly and with careful titration. Reversal of general anesthetic is preferably done with Sugammadex because it is suitable for aminosteroid muscle relaxants, the non-depolarizing muscle relaxants, the rocuronium and vecuronium, and it has minimal hemodynamic effects. If we must use glycopyrrolate and neostigmine, it must be used with caution because of the side effects of bradycardia, hypotension, and arrhythmias. Extubation of these patients must be done when patients are fully awake. Postoperatively, these patients are nursed in the high dependency unit or intensive care units. Continuous monitoring of their pulse rate, peripheral oxygen saturation, temperature, and fluid balance is continued in the postoperative periods. Electrolytes are monitored, renal function is monitored. Signs of decompensation we are on the lookout for signs of decompensation. Supplemental oxygen therapy is continued, pain control, because we want to avoid tachycardia and hypertension. We avoid fluid overload.
Hello, Dr. Onduma. I think she's having a network challenge. Maybe we should give her a few minutes to resolve that and join us. Thank you. We apologize for the break in the delivery of the lecture. We are trying to reach out to Dr. Ndoma to continue. Meanwhile, please, if you have questions, you can drop them in the chat box. And we are advised to rename our devices to reflect our full name. Thank you. Instead of device names. Thank you, sirs and mas.
Good evening, everyone. Please, I'm sorry for that. Please, can you hear me now?
Dr.
Yes,
Nduma, you're
yes,
welcome
we are
back.
audible.
We can hear you. Please continue from where you stopped.
Okay. Postoperatively, please, I'm so sorry for this glitch. Please, can you see the screen?
We can see your screen, Dr.
Yes,
Nduma.
we can see us. Okay, thank you. Postoperatively, the patient is managed in the high dependency unit or in the intensive care unit because we need to ensure close monitoring of the pulse rate, the peripheral oxygen saturation, temperature, and fluid balance to avoid fluid overload. Pain control is continued in the postoperative period with opioids or regional anesthesia if regional oxygen therapy continues in the postoperative period and early resumption of heart failure medications as soon as possible postoperatively. We also look out for these complications: cardiogenic shock, pulmonary edema, myocardial infarction, ventricular defibrillation, acute renal failure, or thromboembolism. So to prevent this, we would continue the anticoagulant therapy soon after surgery. and then monitor fluid input, adequate pain control to prevent acute injury. In conclusion, heart failure significantly increases the perioperative risk. Optimization of this patient preoperatively is crucial, and every patient should have an individualized anesthetic plan. Vigilant monitoring intraoperatively is important. Thank you for listening.
All right. Thank you, Dr. Doma Victoria, for the presentation. Now we welcome questions from the lecture. I'll start with the questions in the chat box. We have a question from Dr. Ishola. She asks, you mentioned anticoagulants and when to stop. Do we need to bridge? And what if they are on DOACs, that's directly observed anticoagulants? So, Dr. Victoria, would you like to attend to the question in total or you attend to them one by one?
Attend to them one by one.
Okay, so your response to this?
Okay, if the patient, the bridging is instituted if patient is on warfarin therapy. If the patient is on DOAC, we do not have to bridge. They can continue taking their anticoagulant therapy until the day before surgery. Please, did you hear my reply?
Hello, we can hear you now. I myself could not hear you what you said last. I don't know if that's generic or just my device here, my network here.
On direct oral anticoagulation therapy do not need bridging because they can continue taking their medications to 1 day prior to surgery.
Okay. What about patients that are not on DOACs, that are on probably injectables?
On warfarin therapy, we need to stop 5 days prior to surgery and commence low molecular weight heparin until 12 hours prior to surgery, or unfractionated heparin until 12 hours prior to surgery.
Thank you. Do we have other questions? Are there other questions from the lecture?
Yeah, my hand is up.
Okay, so some people are raising their hands. We can see Dr. Tokwala, sir.
Yeah, good evening, colleagues, senior colleagues, and then thank you, Dr. Doma. That is a fine one. You've done very well to make this presentation. One thing I need to inform the House is that in making this presentation from your outline, you should spend time to discuss the pathophysiology. We need to understand the pathophysiology of heart failure in the perioperative space and how to manage the complications that arise from it. And in defining heart failure, and then the types of heart failure. You also skipped, you know, classify heart failure either perioperative fields. Is it heart failure from MI that occurs within the perioperative field that you're managing, or is it heart failure? You didn't talk about that. It's important to state: is it active heart failure? Is it chronic heart failure? You talk about the medications, and then what medication will you use to manage the heart failure? You did very well in trying to classify them, into right-sided, left-sided, and the congestive, even though you use the congestive aspect of it. But what medication will you use to manage the complete failure? And it's coming for a cardiac heart failure, it's coming for a neuropathy, and it has low ejection fraction. How will you manage? These are the areas, the context you need to define. The presentation, so it makes it have, could be a non-hypertensive. As the perioperative field, the person that presents with either a right-sided or acute left-sided heart failure. So how will you identify it? How will you manage the patient? So these are the key issues you must state in your presentation, make it clearer. Somebody has low ejection fraction and is going for a neuropathy. How will you manage the patient? How does it present, and how will you manage? Or somebody has chronic heart failure, is coming for maybe from constrictive pericarditis, and is coming for a section of the pericardium. How will you manage the patient? Is coming with right-sided RV dysfunction. What medications will you use? And the medication is used for managing the pulmonary edema from cardiac failure. You didn't mention any of them. You don't gloss over those things because there are things you see on daily basis in your.
I think we lost Dr. Kwala to network challenges. Dr. Oyi, your hand is up, sir. Or ma. Sorry, I don't know whether it's male or female.
Is that we?
All right.
So, Dr. Fiawi. Yes. Thank you, Dr. Doma, for your presentation. It's this heart failure is quite an extensive one. It's not something you give over an hour, to be fair. There's just there are a lot of questions, but I think I'll just focus on setting some of them. First and foremost, to correct an impression. Anticoagulants are not given to all heart failure patients. So I think that's something that needs to be corrected. Now, heart failure patients, some of them, heart failure patients can be predisposed to atrial fibrillation. And that's because of some of the fibrosis, the long-standing chronic failure that would have happened. So because of that, some fibrosis would have happened within the heart that prevents re-entry of electrical activity. So this predisposes to atrial fibrillation. And that means that the heart is fibrillating. There's a tendency to throw clots. Those patients are the ones that are at risk of embolus. So you give anticoagulation where you are giving your DOAC. That's the direct oral antithrombotic agent. Those ones, yes, but not because the normal heart failure patients usually, whether acute or chronic, is usually in sinus rhythm. So you do not necessarily just go and start giving prophylactic anticoagulant because they can be at risk, because the drugs itself are always like poisons. That's one of the things I wanted to say. Now, the other thing I also wanted to mention was that in terms of your management, which is also important, the anesthetic area for this kind of patients, the kind of medication that you're also giving, because there's some, I know you mentioned beta blockers, but there are some patients that you would also be careful about giving beta blockers. And again, that's what the previous speaker, I think Dr. Can't remember what his name now, was saying, is that some of these patients, when they're coming in, you have to also remember that you don't just rush them into theater. You have to also learn to optimize patients. They will come in decompensation. And these patients who are already decompensated, already hypotensive, these are not the kind of patients you want to be giving beta blockers to. Some of them may be in pulmonary edema. You're not going to be giving them beta blockers because beta blockers itself will slow down the heart rate, will slow down contractility as well. And these are things that means that in terms of sending blood and oxygen around the body circulation-wise will be affected. So this is where your digoxin comes into play. And if, for example, their blood pressure was even okay, optimized, you'd probably be thinking about giving even GTN infusion for this kind of patients. Now, for your induction agents, I know you mentioned propofol. Propofol, you also be very careful because of its hypotensive nature. You'll probably be thinking about giving. I know there's some. I don't know how many centers are have private to using keto products, ketamine and propofol. Otherwise, you use cardiostable drugs, etomidate, for example. That would be a better agent for your induction. In fact, it's usually said that for patients who are decompensated, your intravenous is usually better. It's better to use your intravenous instead of inhalation because those ones will also depress contractility and all of that. So is that area in terms of your anesthetic management, also your AD, because these patients, a lot of them, when they're decompensating or they're when they're decompensating, how you manage them will determine what the outcome will be. So it's always important to note that in your presentation. The other thing also, sugar madex is if, for example, you use things like atracurium, you give muscle relaxant and you use succinylmetonam and then you give atracurium. Sugar madex is usually for when you're using for rocuronium, vecuronium, not for atracurium. So you also have to know the differences between non-debularizing and all of that, and know which of them sugar madex is specifically for. So it's not just that you give sugar madex to every patient. There are specific patients and agents that sugar madex will reverse. So it's good for you to understand the concept of those things and all. I think I'll stop there. It's quite an extensive one. It's quite a lot of questions for. I would say that you tried in terms of trying to work with the time frame, but that's I think just take note of those questions that I have or things that I've said. All right, thank you.
Thank you, sir.
Thank you very much, sir.
All right.
All the observations are duly noted. I don't know if we have any other question. I can't see any more hands, and I can't see any more questions in the chat box. So, in the absence of any other question, I want to appreciate all our teachers, our professors, consultants from all over the country that have made an effort to be present in this presentation, and for your contributions. We thank you very much, sirs and mass. We appreciate you. Thank you, Dr. Ndoma, for making yourself available and presenting such wonderful presentation to us this afternoon. And I want to thank all the participants that made time out of our various busy schedules to attend this seminar also. Thank you very much. And for those brilliant questions that we had from Dr. Ishola, thank you very much. So we are going to round up very soon. I want to particularly acknowledge the head of the educational committee of the Nigerian Society of Anesthetists and the president-elect of the NSA, Professor Kalu.
Thank you, everybody. Thank you for joining the webinar today. It's been a very wonderful time. I want to appreciate Dr. Afam and the residents. Please, whenever you're called upon to present, make yourself available. I thank Dr. Joe Botokwala for the very meaningful input into this presentation. Remember to pay your NSA dues, please. And the WCA is just a few months away. For those who are interested, make sure you get all your things together. We are going to have a stand at Morocco for the WCA. Thank you very much for joining, and God bless you all.
Thank you very much, ma. Prof. Thank you, ma. So in the absence of any other questions and contributions, we want to appreciate everybody for making it a day today. Next month will be another encounter, and we pray it to be more fruitful than it is today. So thank you very much, all of us. Have a nice day. See you next time. Dr. Balita. Dr. Babatunde Obalisa.